Hey everyone, and welcome. If you're in nursing school, you know that checking on a baby's well-being is one of the most high-stakes things we do. So today, we're going to build your essential toolkit. Think of this as your high-yield study guide for the key procedures you've absolutely got to know for your exams and, more importantly, for your future patients.
So picture this. You walk into a room and your high-risk patient is worried because she hasn't felt the baby move as much. Your heart rate goes up a little, right? That feeling of, okay, what's my next step? That's exactly why we're here. The tests we're about to cover are your answer. They're how we get the crucial information we need to keep everyone safe.
First up in our toolkit is probably the one you're most familiar with, the ultrasound. It's pretty amazing, really. We use high-frequency sound waves to get a real-time window right into the womb. This lets us actually see the fetus and everything around it. It's our go-to first look to figure out what's going on.
Okay, you're going to want to pay close attention here because this slide is full of classic exam questions. We've got two main types of ultrasound, and the prep is totally different. For the abdominal one, the one on the outside of the belly, your patient needs a full bladder. But for the transvaginal one, which is internal, they need an empty bladder. You will see that again, I promise. The abdominal is great after the first trimester, but the transvaginal gives us a much clearer picture early on.
All right, here's your memory anchor to lock this in so you never forget it. Just think of that full bladder as a little platform. It literally lifts the uterus up and out of the pelvis, giving us a much better angle and a clearer picture. It's that simple. Just remember, abdominal equals full bladder. Got it?
And you might think ultrasounds are just for those first cute baby pictures, right? Well, they do so much more. Of course, we use them to confirm the pregnancy and see if there are twins in there. But we also do really critical stuff, like track the baby's growth, find the placenta to rule out dangerous conditions, and even check the amount of amniotic fluid. It's even our eyes guiding the needle during other procedures we'll talk about in a bit. It's an incredibly versatile tool.
Okay, so let's build on that. We're moving from just looking at the baby to actually testing how it responds. This is where we start to get a sense of how healthy the baby's central nervous system is, and we'll start with something called the Nonstress test, or NST.
The NST is pretty much exactly what it sounds like. We're not adding any stress, we're just watching to see how the baby's heart rate reacts when it moves around on its own. Basically, we strap on two monitors, one to track the baby's heart rate and another to pick up any contractions. The mom clicks a button when she feels movement, and we're looking for the heart rate to speed up, just like ours does when we get up and walk around.
Now let's pause for a common clinical situation you'll definitely see on an exam. What if the baby isn't moving? Well, it might just be taking a nap. So to get a true result, we sometimes use a little vibroacoustic stimulator. It's basically a gentle buzzer we place on the mom's belly. It's just enough to wake the baby up so we can see how its heart rate responds and we can avoid a false alarm.
So this is the really crucial part, knowing what the results actually mean. A reactive test is what we want to see. It's normal and reassuring. It means the baby's heart rate went up by at least 15 beats per minute, stayed up for at least 15 seconds, and did that at least twice in a 20-minute window. A non-reactive result, on the other hand, is our big signal that tells us, hey, we need to look a little deeper.
So what happens if that NST comes back non-reactive? Well, one of our next steps might be a contraction stress test, or CST. Now, this time we are adding a little bit of stress to the system. We trigger some mild contractions to mimic labor, and we watch very closely to see how the baby's heart handles it. This tells us a lot about how well the placenta is working under pressure.
And man, this is where the stakes get really high. A negative CST is the good news. It means the baby handled the contractions just fine, no problem. But a positive CST, that's our red flag. It means the baby's heart rate dropped after contractions, which is a sign the placenta might not be delivering enough oxygen. This is a major warning sign that the baby might not tolerate actual labor.
Okay, so what if we need an even more detailed look? That's when we turn to the Biophysical profile, or BPP. The best way to think about this is like a full-on report card for the fetus. It combines that non-stress test we just talked about with a detailed ultrasound assessment. This table right here, this is your study guide. You're going to want to know this. The BPP scores 5 key things, and it's simple. You get a 2 for normal or a 0 for abnormal. We check for a reactive NST. Then with the ultrasound, we look for fetal breathing movements, big body movements, good muscle tone, and finally, enough amniotic fluid. The final score gives us a really solid picture of the baby's overall health.
So you get the results back and the score is a 4 out of 10. What does that mean? Well, yeah, that's not good. A score that low is really concerning.
It strongly suggests the baby may have been dealing with a lack of oxygen for a while. This is a score that gets everyone's attention and means we need to act, and act fast.
All right, let's shift gears to our final set of tools, the invasive procedures. Now, these aren't routine. They're for higher-risk situations where we really need to get a direct sample from inside the womb to diagnose a specific condition or check on the baby's health at a deeper level. When it comes to an amniocentesis, the nurse's role is absolutely critical. Let's break it down. Before the procedure, you make sure consent is signed and you tell the client to empty their bladder. Remember the abdominal ultrasound? We needed a full bladder. For an amnio, it's the total opposite, and it's to avoid poking the bladder with the needle. During, you'll get the client positioned and monitor everyone's vitals. And after, you keep monitoring. And this part is huge. You give RhoGAM to any Rh-negative client.
Okay, stop what you're doing and listen up, because this is a massive NCLEX tip. Anytime there's a procedure with a risk of moms and babies blood mixing, and the mom is Rh-negative, you have to give RhoGAM. It's all about preventing her body from creating antibodies that could harm a future baby. It is a super important safety intervention.
So we've got this amniotic fluid. What are we looking for? Well, a few key things. We look at a protein called AFP. High levels might point to something like a neural tube defect, while low levels can be linked to chromosomal disorders. We also check something called the LS ratio. All you need to remember is that a ratio of 2 to 1 or higher is the magic number that tells us the baby's lungs are probably mature enough to breathe on their own after birth.
And just to round out our advanced toolkit, there are a few other tests you should have on your radar. Chorionic villus sampling, or CVS, can give us genetic information even earlier than an amnio. The quad screen is a simple blood test for mom that just screens for risk. And PUBS is a highly specialized test where we actually get a blood sample from the umbilical cord, usually to check for something specific like a severe infection.
All right, deep breath. You've got all the tools in your toolkit. You know what they do and what the results mean. Now, let's put it all together and think like a real nurse using that clinical judgment model. Let's apply this to a scenario.
Okay, let's break this down. First, you recognize the cues. What do you see? A client with high blood pressure, a non-reactive NST, and then a positive CST. You put those pieces of the puzzle together and analyze them. This pattern is screaming uteroplacental insufficiency. So you generate your hypothesis. This baby is not getting enough oxygen and will not tolerate labor. So, what is your priority action? You take action. And that action is preparing for an imminent birth. That means calling the provider immediately, getting the team ready, and anticipating a probable C-section. That kind of thinking, connecting the dots from test results to immediate action, that's what saves lives.